Ladies and gentlemen, welcome to the Young Physicians Forum and College Lecture. We are going to start the Young Physicians Forum and College Lecture afterwards, and the lunch will be distributed afterwards. And for the Young Physicians Forum,
the next lecture is by Dr. Praveena Jayasena, Registrar in Neurology, Lecturer from Lanka.
Controversies in Acute Ischemic Stroke Care, a Kaleidoscopic View. And over to you, Praveena.
Good afternoon. Thank you, sir, for the introduction. And I'd like to thank the college for giving me this opportunity. So my topic for today is controversies in acute ischemic stroke care, a kaleidoscopic view. So for the next 25 minutes or so, I will be discussing some key important therapeutic dilemmas in stroke medicine and highlight some major aspects where we can increase our awareness and be better prepared to help handle these challenging cases which we encounter as clinicians. So this is a brief overview of my talk. We are going to talk about the two different types of thrombolytic agents. We are going to talk about primary thrombectomy versus thrombolysis with thrombectomy versus thrombolysis in special populations, and what is the optimal timing to restart anticoagulation after stroke. So we'll go to a case, 45-year-old female with type 2 diabetes and hypertension, presenting with right dense hemiparesis, severe aphasia for the last 4 hours, NIHS 18. NCCT brain shows a left hypertense MCA sign. Would we thrombolyze? If there are no contraindications, yes, we most probably would. But the next question is, what are we going to use? Is it tenecteplase or alteplase? Let's talk about some basic pharmacological properties of tenecteplase. It's a third-generation novel thrombolytic agent that is bioengineered variant of the second-generation alteplase. And it's a more fast onset of action, and it has a longer half-life of 24 minutes, and it is more fibrin specific, up to 15 times more specific than alteplase, and it is more resistant to breakdown of the clots by compared to alteplase. And it is also easier to administer. We give it as a single bolus, so compared to alteplase, and this is a cost-effective drug because you save the time on IV infusion pumps, IV lines, door-to-needle time, and ultimately you save money. So, and also the trials have shown that they produce a small infarct volume compared to alteplase, which we will discuss. So there have been several major randomized control trials, as you can see on this table, that has been a head-to-head comparison of alteplase versus tenecteplase. To see if there's an improvement in the 90-day functional outcome, or if there's a smaller size in the infarct core volume, or if there is an increased rate of symptomatic ICHs or intracerebral hemorrhages. So what I've marked in yellow is the trials that have shown non-inferiority of tenecteplase compared to alteplase, which means that tenecteplase is not better than alteplase, but it is as effective as alteplase. So, and there's one landmark trial called the Extend IATNK, which I'll talk about a little later, which is marked in blue, that has shown to be a superior efficacy of tenecteplase when given in large vessel occlusive strokes. So, they have done a meta-analysis of all the randomized control trials of tenecteplase versus alteplase, and they have shown, as you can see in this forest plot, there is a non-inferiority of tenecteplase when compared to alteplase when it's at a dose of 0.25 milligrams. That is, it is as safe and effective as alteplase in acute ischemic strokes. And you can see in the forest plot, there is a composite diamond endpoint, as well as the other point measures. They are all crossing the midline, so that signifies non-inferiority. However, there is a little caveat. If you give tenecteplase as a higher dose of 0.5 milligram per kg, it is shown to be effective, but there's a high rate of intracerebral bleeds. And this is just a visual representation of tenecteplase versus alteplase. It shows that tenecta is more effective in achieving early neurological improvement and recanalization rates compared to alteplase. However, the a 90-day outcome and the safety of the risk of having symptomatic ICHs are more or less the same in both groups. And as I mentioned earlier, Extend IA TNK trial was a landmark trial that compared effects of tenecteplase when given as an IV thrombolytic agent prior to going thrombectomy in large arterial occlusive strokes. And as you can see, tenecteplase causes nearly double the recanalization rates and more improved excellent functional recovery at 90 days compared to the altiplase group. So this was a landmark trial. And then this is also highlighted in the forest plots. As you can see, as I mentioned, it has a more potent clot lysis effect as well as improved 90-day functional outcome. But then there were other trials, observational studies, and even real-world data that started showing that actually tenecteplase may actually have a less late rate of symptomatic ICHs compared to altiplase. And there are ongoing trials about tenecteplase comparing altiplase when given to minor strokes or when given to disabling strokes or when it is given for an extended thrombolytic window beyond 4.5 hours. So for wake-up strokes as well. So there's ongoing trials which we are highly anticipating in the future. So the guidelines are saying tenecteplase for AHA and ASA, they are saying it's a reasonable to consider tenecteplase in large vessel or occlusive strokes prior to giving thrombectomy in those patients. However, the European and the Canadian guidelines have strongly recommended only altiplase, which is a FDA-approved drug. Tenecteplase is still an off-license label drug. So then there came this argument that if thrombolize a large proximal clot at a very accessible site, then the thrombus can break off and it can go downstream and cause distal occlusion, thereby causing more disabling strokes. So that in which case that you cannot access with the catheter. So then there came this huge controversy of whether thrombolysis with thrombectomy, which is called bridging, versus thrombectomy alone is better, because if you do thrombectomy alone, you save the time of thrombolysis and you can go straight to the cath lab. So this was addressed by several randomized controlled trials, and 2 Chinese trials tried to address it and showed non-inferiority. However, they were methodologically flawed. And there were several European and Japanese trials that showed that did not show actually the same efficacy of thrombectomy alone versus bridging therapy with thrombectomy. So none of these trials have managed to prove that thrombectomy alone is effective or superior compared to bridging therapy with thrombectomy. So, so our standard practice of care is still we thrombolize the patient, then we send for thrombectomy in large arterial occlusive strokes within 6 hours. So the next case, 37-year-old pregnant lady with a P2C naught, POA 22 weeks, having a 90-minute onset of global aphasia with right hemiparesis. NIH score is 12. MRI showing a left M2 occlusion, and there is a diffusion-perfusion mismatch on the MRI. So are we going to thrombolize this patient? Let's talk about pregnancy first. So pregnancy is a physiologically hypocoagulable state due to increase in the thrombotic factors, especially the clotting factors 2, 5, 7, 8, 9, and 12, and lower levels of protein S. This is an adaptive mechanism to overcome any bleeding during delivery. And there is an increased incidence of stroke in pregnant patients. Every 100,000 cases will have 30 ischemic strokes, which is not uncommon. And it can cause at least 5% of maternal mortalities. So in terms of imaging, MRI is considered to be the standard of imaging. And if MRI is unavailable with diffusion-weighted imaging, then we go for an uncontrast CT, which is acceptable because studies have shown that the ionizing radiation effect of non-contrast CTs is still lower than the threshold required for fetal toxic radiation. So, and the mother has to wear a lead apron as additional protection to shield the uterus. Iodinated contrast is also shown to be safe in pregnant patients with a very few cases of transient neonatal hypothyroidism. Now, thrombolysis-wise in pregnancy, altiplase is a very large molecule. It doesn't cross the placenta. So it technically doesn't have any mutagenic effects and teratogenic effects on the fetus. And it's shown to have a very low bleeding risk in otherwise healthy young mothers. And again, why aren't there much data on thrombolysis in stroke patients? because it's very unethical. It's considered unethical to put them in randomized trials, and there's safety concerns for both the mother and fetus. So we don't have any strong recommendations for thrombolysis in pregnancy patients. And there have been few isolated case series showing that 2 out of 20 mothers have had symptomatic ICHs, or one may have an intrauterine bleed. And there's one study that showed there's increased risk of placental separation at 12 weeks post thrombolysis with tenecteplase. And again, this study is just to show that early pregnancy patients who've had ischemic stroke underwent thrombolysis, other than one patient who's had a death unrelated to thrombolysis. All the others were good outcomes and healthy babies. And again, so the AHA ESO guidelines, they cautiously considered saying giving thrombolysis in pregnant mothers with acute, moderate to severe disabling strokes is acceptable, provided that they meet the eligibility criteria and the benefits outweigh the risks of uterine bleeding. And again, this was extrapolated to the large arterial occlusive strokes, saying that they may be also benefiting from mechanical thrombectomy, provided they present within the required time window and appropriate imaging. That this all has to be done on an individual case-by-case assessment. So the next patient, 85-year-old male with type 2 diabetes, dense left arm, face arm leg weakness for the last 2 hours, and NIHS 14. Would you treat? Okay, we'll get to that. So nearly 1/3 of ischemic strokes are occurring in the above 80-year-old patients. And you know, with increasing life expectancy thanks to the better healthcare and technology, we are only going to see the doubling of the rates of ischemic strokes in elderly. And so why are we depriving these octogenarians of thrombolytic therapy? The reason is they're actually heavily underrepresented in the clinical trials and randomized data. So are we ageist here? That's the question. So, and this was nicely demonstrated by a European study that shows, you can see the red colored circles are randomized trials and the blue colored circles are observational cohort studies. And there was a wide age gap in these groups, and all the inclusion ages for this is below the age of 80 almost. So, so this was, you know, this raised a couple of eyebrows, and we now are aware that elderly patients are frail, and there is a risk of frailty, and they may have multiple comorbidities, polypharmacy, they have different pharmacokinetics due to renal clearance, and they have a higher tendency to have cerebral amyloid angiopathy that puts them at risk of symptomatic intracerebral bleeds. And this was also addressed by this TRISP collaborative study that involved a cohort of nonagenarians, which is more than 90-year-old patients. And they beautifully demonstrated this reassuring data that those who were thrombolized within the window of 4.5 hours, they actually did not have a higher rate of ICH than their younger counterparts. So this again was a bit of a surprise. And more trials were done. And then again, it's not only the safety, the efficacy was also proven with these patients who were thrombolized at old ages, as you can see on the forest plot. So, and then they also looked into the effects of detrimental effects of altiplase on the age. And surprisingly, the data other than the 94, 90, 92, 93-year-olds group, up to that age, most of it was independent of the age. So again, this raised a lot of awareness, and now people are starting to consider whether thrombolizing in elderly patients is a worthwhile endeavor. And as you can see in these randomized control trials, they have shown that there is an excellent recovery of the functionality for following post-stroke in patients who've been thrombolized with at least 6% improvement, and there is a non-significant decrease in the deaths. So again, as I mentioned here, so thrombolysis within the 4.5 hours in elderly patients is strongly recommended. However, they caution us on thrombolizing patients who have cerebral amyloid angiopathy, particularly if they are more than 10. And so age alone should not be a restricting factor to deprive these patients of these thrombolytic therapy. And now it's extended into other treatments as in cases such as wake-up stroke, as stroke of unknown onset, etc. And full dose of altiplase can be used in elderly. So the next patient who is 58 years old with dense right hemiparesis and facial weakness for 3 hours, NIHS 14, and patient is on apixaban 5 milligrams for non-valvular AF, and last taken at 8 hours ago. NCCT is normal. This is a commonly encountered scenario now in ETU. I myself have encountered several times. Are we going to thrombolyze? Okay, just a brief reminder that these clotting factors, particularly factor 2 and factor 10A, are inhibited by the DOACs. Okay, so the guidelines so far, the AHA and the ASA and the European guidelines unanimously agreed that to avoid thrombolysis in patients who have taken a DOAC for the last 48 hours. So they are quite vehement on that. And however, the Japanese trials have a more practical approach where they say if the patient has taken a DOAC more than 4 hours and they come with an acute ischemic stroke, it is relatively safe to go with thrombolysis provided that the INR is less than 1.7. And if the reversal agents such as derazumab is available for dabigatran, which is very scarce even in developed countries, you can go ahead with reversal as well. So then this meta-analytic data showed of these 6 randomized trials showed that there is no significant increase in the symptomatic ICHs in the patients who had the DOAC within 48 hours compared to those who had no anticoagulation. So then again, this raised a couple of eyebrows, and this was addressed again in another recent randomized trial. And they sorted the patients into 3 different groups. So patient has to come with an acute ischemic stroke within 4.5 hours, and they may have taken the DOAC within the last 48 hours. So they can be put into 3 groups. Either they can receive the reversal agent if available, that is, or they can only measure the plasma levels of the DOAC, and that is done because you can measure the threshold for treatment. If it's low, then we can treat them with thrombolysis. And then the third category, they had no reversal, no serum levels measured. And surprisingly, again, the data showed that the symptomatic ICH rates were significantly lower in the patients who had DOAC groups compared to those who were not on anticoagulants. And regardless of whatever strategy they use, all these patients consistently had a lower symptomatic ICH throughout the trial. So why is this paradoxical reduction in the ICH rates in patients who are on DOACs? So there is only a hypothesis. This is not a theory that the DOACs directly inhibit the factor 2, which may actually block the blood-brain barrier from being broken down. So it reduces the risk of having symptomatic ICHs, and then it helps in faster recanalization as well. So now the DOACs being given in the last 48 hours is now used to be a relative contraindication, and it used to be a contraindication when we were actually registrars. And now it should be a relative contraindication, like what happened to warfarin. Now we give warfarin if the INR is less than 1.7. Dual antiplatelets are now given. So there is a clear change in the treatment paradigms and the guidelines for these special scenarios. So these are as I mentioned earlier, so you have to take each case by individualized case-by-case approach. We can't be blind followers of guidelines. That is why we are there as physicians to identify individual patient risk factors and treat appropriately. So, and also one of the other points to note is for the registrars, particularly prophylactic low molecular weight heparin. In the past, it used to be if given within the last 12 hours, it's relative contraindication, but it's now the World Stroke Congress and the organizations have unanimously agreed that according to expert consensus, this should not be a contraindication for thrombolysis, provided the APTT cutoffs are within the appropriate margins, or reversal agent may be given. So when is it optimum time to restart anticoagulation in these patients after stroke? Right. So one of the major issues is it safe to start within 2 days or 5 days or 6 days? So this was addressed by a collaborative cohort study called the Samurai and the Relaxed trial. So they looked into starting early DOACs in groups compared to starting it late. So the early DOAC treatment group was started on the simple 1, 2, 3, 4 basis based on the stroke severity. So TIA, minor strokes, moderate strokes, severe strokes. And that was measured using MRI imaging, volume size measurements of the infarcts, etc. And then they compared it with the later group of starting, which is 2, 3, 6, 9 rule. As you know, when we were registrars, we used to study 1, 3, 6, and 12 as the cutoffs. But now this, as you can clearly appreciate in this Kaplan-Meier tables, the red line showing early DOAC initiation has significantly reduced the number of recurrent embolic strokes as well as other systemic emboli, such as PE, etc. And it also reduces the number of other complications such as intracerebral hemorrhages, and it reduces other major bleeding elsewhere. So then the trial basically concluded saying, okay, so now they came up with this practical catchy line of 1, 2, 3, 4 should be considered for DOACs. But bearing in mind, we have to consider patient's age, the severity of the stroke, so the size of the infarct through neuroimaging, and the blood pressure, because all of these factors are risk factors for hemorrhagic transformation, which is the most feared and sometimes the disabling complication of post-thrombolysis patients. However, the European and the NICE guidelines were more cautious in their approach. And still, according to the expert consensus and the trial data, they are saying they would consider restarting DOACs or even vitamin K antagonists such as warfarin on the grounds that based on the stroke size. So if it's a TIA, you start it after 1 day. Or if it is a minor stroke, NIHS 0 to 7, you start the DOACs within 5 days. Or if it is moderate stroke, NIHS 7 to 15, you start the DOACs within 7 to 14 days. And if it's a large stroke, NIHS more than 16, you start the anticoagulation at least more than 14 days. And there are other instances where there is a parenchymal ICH patients, you consider starting DOACs within 2 to 6 weeks. The guidelines are not very specific on the exact time point. So again, my point here is to enlighten you on the fact that these are all individualized case-by-case approach. And there are instances where anticoagulation is contraindicated due to risk of bleeding. In such patients, especially for patients with cardioembolic stroke, we might consider other kind of issues, especially if they have an AF, you might go for a left atrial appendage closure device that is like the final resort. And that has also shown to reduce the number of embolic strokes. And interestingly, there was a study that showed that AF ablation does not actually lower, although it reverts them to sinus rhythm, it does not lower the risk of having stroke. So then there came this talk whether cardiopathy itself, whether the structural defect itself is more accountable than the arrhythmia causing these embolic strokes. So, ladies and gentlemen, so we have gone through some of the most gray areas of stroke management. And I hope that through this discussion, you're a little more enlightened about how to approach these therapeutic dilemmas. And we should also have a more patient-centered approach. And with this, and I think my talk is actually in keeping with the theme of the Ceylon College of Physicians, which is inclusivity, where we include all patients, regardless of their age, elderly patients and pregnant females or differently able patients, having a diverse cohort of patients in the treatment window. And so we are broadening our therapeutic wings to accommodate these patients. And by doing so, we provide them optimum effective medical treatment, ensuring everyone gets equal medical care and ensuring better quality of life for patients. And what I want to highlight here is the stroke medicine is a constantly evolving field with new and improved updates on guidelines. and everything is changing. What we used to think as a relative contraindication or absolute contraindication within a few years' time may turn out to be an absolute inclusion now. So keep an open mind, and I'd like to again thank the CCP for giving me this unique opportunity. These are my references. Thank you.
Thank you, Praveena, for that wonderfully delivered lecture. And now it is open for discussion and questions.
Thrombolysis, what about the wake-up stroke from 4.5 hours to 9 hours? The recent Sri Lankan guidelines seem to have calculated the time the patient went to sleep and wake up time and take the mid time of that.
Yeah, excellent question, sir. So, yeah, so what they're basically saying is, so wake-up stroke, there's two entities. There's wake-up stroke and the last well-known time. So when we get a patient who's coming with a wake-up stroke, we don't know the last time they were last well. There are some times like that. So the European, the AHA guidelines, and even the Sri Lankan guidelines, including the NICE guidelines, what they've adapted is they're basically taking any patient who's gone from the time they've slept, from the midpoint of the sleep, right up to the time they're presented with the stroke. It should be between 4.5 hours to 9 hours. So by the time they get the CT done, if they're still within the midpoint of the sleep, okay? So if they're in the midpoint of the sleep, up to the point they have come with the stroke to the ward, the hospital, until the CT is done, if they're presenting within the 4.5 hours to 9 hour window, then we are still in the game. That is what we call this tissue clock. Because what used to be in medical school, we used to learn as time is brain, time is tissue. Now it's no longer that. So we are going not only by the patient history, because some patients may be aphasic, some patients may not be able to give a history. In those instances, what they're saying is, if the patient comes to you with a wake-up stroke, the last time they have so if they know the last well-known time, and they are able to now, if we are still within the 4.5 hours to 9 hour window, and we do the imaging, then the imaging, ideally, we should go for an MRI with a DWI flare mismatch. And there are three things that you look for there. So it has to say, you have to have a small infarct volume that is less than 70 ml. You have to have a penumbra, the salvageable penumbra and the infarct should be, there's a mismatch. So there should be a ratio. If the ratio is more than 1.2, or if at least there's a 10 ml of salvageable penumbra, if they meet all those three criteria, then, and if they're still within this 4.5 hours to 9 hour window of wake up or last well-known time, we're still in the game. We can still go ahead with thrombolysis. So I'd like to, clarify that doubt. I mean, may not be very clear in the guidelines. Sometimes what you need to know is, if you're in 4.5 hours up to 9 hours, and if you have woken up with a stroke, or if you don't know the time, and at least from the midpoint of the sleep to the time of presentation, 4.5 hours to 9 hours, or if they know the last well-known time to now, 4.5 to 9 hours, in those instances, we go ahead with the imaging urgently as soon as possible. And if you see these mismatch criteria, you go for thrombolysis. And then whatever afterwards, thrombectomy if needed.
Praveena, there are these people who are on aspirin and clopidogrel. Oh, it's inclusivity. When they get a stroke, you take them with pain. And what are you going to do for them to stop them getting another stroke in future? What's the drug?
So what you're saying is patients who are on dual antiplatelet therapy coming with for ischemic heart disease, whatever. So what you want to know is, what are the treatment modalities available in terms of long term? Good question, sir. What the studies have shown is, ideally, clopidogrel and ticagrelor, those are the other new agents. Ticagrelor, they are shown to be slightly more effective in stroke prevention compared to clopidogrel. But there's ongoing debate as to whether to add a third agent. So there is another trial called the Extend-I extend IA DAPT, that is basically looking at whether we can start another third antiplatelet agent, whether it's beneficial. But that only increase the number of bleeding. So at the moment, there is no second line treatment for giving additional as a prevention of secondary prevention for stroke. But I'm open for anyone else if they can give their input. But as far as I know, there's no real one drug that fits all, kind of covers for both dual antiplatelet secondary prevention for stroke.
Thank you very much, Praveena.